Hi guys, this is John Adamson, the Rehab Documentation Guru, and what we're going to do is a brief video today on talking about comparing your treatment diagnosis to your clinical findings. It's very important that if you choose treatment diagnoses on your plan of care or updated plan of care, you have solid objective measurements to back that diagnosis up. And a lot of times I've seen issues with evaluations where therapists use diagnoses that have no clinical backing, and that's problematic. So what we're going to do is we're actually going to look at a two-discipline case where both PT and OT were in, and both use the same three treatment diagnoses. They use generalized muscle weakness, other lack of coordination, and abnormal posture. To start off, let's talk about the patient. This guy was a 72-year-old male, status post left CVA 3 weeks ago, and now he's seeing you for post-acute care. Now, the patient did have several functional deficits related to mobility and ADL, so both PT and OT had good reason to be in on the case. Now, the underlying impairments, and if you've been to my course on documentation, you know what underlying impairments are, but for those of you that don't, let me just explain real quick. Underlying impairments are the things that cause functional deficits. So if the patient's having trouble getting up and down from a chair, it's because of an underlying impairment. Could be lack of strength, lack of range of motion, lack of balance, lack of coordination. So things that we can measure, things you learned how to measure back in the day called school, things that you have expertise to address, there are underlying impairments to that functional deficit. So the PT and OT had done some measurements of underlying impairments, and this is what they found. Both PT and OT measured the right affected side of the patient and measured the patient at 4 out of 5 or greater. Now let me tell you right off the bat, when a patient gets to 4 out of 5 or stronger, generalized muscle weakness generally is regarded by third-party payers as being something that could be addressed by non-skilled people. Perhaps you could set up a program, home exercise program or a restorative program or whatever it might be, and that will be sufficient to get the patient's strength back. It doesn't necessarily mean that you need to see the patient. So if you do have strength that's greater than or equal to 4 out of 5, number one, I would consider using a standardized test to determine strength rather than using just manual muscle testing. And or number two, be very specific about muscle groups and movement patterns, because just because somebody might be fairly strong doesn't mean that their movement patterns are normal. And that's kind of important. But generalized muscle weakness would have very limited support on this patient, but it is present. Now let's look at the next set of measurements. OT did document that the patient had impaired function on the 9-hole peg test right upper extremity. So they had actually done a standardized test for coordination. That's important because therapists sometimes try to get away with answering the coordination question of being good, fair, or poor. And that is such a subjective assessment, and it's going to be really impossible for a therapist coming in after you to determine what did you mean by good, fair, and poor. So we really need to standardize our assessments. And there's things like the 9-hole peg. There's the finger, nose, finger. You guys might remember when we learned how to do tests for dysdiadochokinesia. I can't believe I just got that word out. You know, there's some fancy tests that we can do that'll help us objectify coordination. Now, PT documented normal coordination. And I do see this fairly often where therapists will contradict themselves. And so even though PT used other lack of coordination in their assessment, they failed to validate it. Therefore, it is not an appropriate code. Now, going on, PT documented that the patient had notable internal rotation of the right lower extremity when ambulating. Now, that is an abnormal posture the patient is utilizing during gait. So that would help justify abnormal posture, and it would be better if the PT could better objectify that with a number, like a range number or something like that. OT has no documented postural findings, therefore abnormal posture cannot be used by OT. And so both these evals The therapist demonstrated lack of objective measurements to support the treatment diagnoses. And it's very important that we always make sure that we've got the support for the diagnostic codes we put on there. If you want to prove the complexity of the patient, you got to measure it. And that's key. Anyway, I hope this little brief video was helpful. Please feel free to like this video. That would be helpful to me. Please subscribe if you're not already a subscriber. And also feel free to leave in the comments if you have any suggestions for topics you'd like to see covered. I'd be happy to cover them for you. Take care. Have a great day.